Someone asked me as I was walking up, and I hadn't planned to speak to this, but because someone asked, what about the events in Charlottesville? Let's just say they are reprehensible, and the degree to which one fringe group filled with hate says that they speak for all others, that is wrong. They don't speak for me, and I suspect they don't speak for you. And so just because someone asked about that earlier, I will comment on that first up. That said, I will do what Julia said I was going to try and do, which is try to speak to that which is coming to completion, because I'm in my third year now. We've been working on stuff the first 2 years. That which is right in the middle of it, and that which we think is going to be the discussion going forward. And so with that said, and I'll hit them, I'll hit high points, and I'll rely upon your questioning to bring out further detail. But again, I'm willing to speak of anything which you wish. Mental health. In 2016, Chris Murphy, a senator from Connecticut, and I collaborated on the Mental Health Reform Bill of 2016, which was put into the 21st Century Cures Act. It was said at the time by some to be the most significant reform of mental health services in the last 30 years. That is important. I will tell you that everyone in this room and everybody who sees us on TV or over the internet has a friend, a family member, some close acquaintance at least, whose life has been destroyed by serious mental illness. And as you might guess, the federal government spends all kinds of dollars. But as you also might guess, oftentimes it is duplicative, and it may work, or it may not. And I will say in Louisiana, when I spoke at the lower 9th Ward, Martin Luther King Community Center, and I said, everyone in this room knows someone whose life has been affected by addiction, every head nods. And then I go to an affluent neighborhood north of Lake Pontchartrain. I say the same thing. Every head nods. This cuts across all of us. So I'm very pleased with the Mental Health Bill of 2016. And my goal is that the 18 or 20-year-old woman who has her first psychotic episode, it is her last psychotic episode. And every resource she needs to return to wholeness is concentrated around her, so that she does once more become whole. And instead of the all too predictable path that we see now, in which her marriage breaks up, her kids go to foster care, she becomes homeless, instead is replaced with, again, a return to health and wholeness, so that when she's 50 years old, she looks back upon that first psychotic episode as her last psychotic episode and as a distant memory. That is my goal. Now let me give a few of the provisions. We encourage the integration of physical and mental health. Right now, before this was passed, if a family practitioner saw a patient for diabetes but found that she was psychotic, if he referred or she referred the patient to the psychiatrist that same day, the psychiatrist could not get paid, and so would have to refer to the emergency room. Similarly, if the psychiatrist saw the patient and noticed the blood pressure was out of whack, then the psychiatrist could not refer the patient to the family practitioner, would have to refer to the emergency room because 2 doctors could not get paid on the same day. We changed that to allow increasing integration of physical and mental health. We strengthened the transparency and enforcement of mental health parity. We established new programs for early intervention and improving access to mental health care for children. By the way, that was something brought to me by Doctors Howard and Joy Osofsky from LSU Health Science Center, New Orleans. Their work post-Katrina found this to be a major issue. They are nationally recognized experts, and we took their information and tried to make the bill better. We strengthened suicide prevention. We established new national mental health policy laboratories to fund innovation grants to find new and effective models. We reauthorized successful grant programs. We developed new educational material. I can go on. But that's an accomplishment, very proud of it. And just last week or the week before, the nominee as the new Assistant Secretary of Mental Health was approved by Congress. and will be taking office, and her task is to cut across the government and to find those duplicative programs, those that are not working, to get rid of them, and to take those resources and concentrate them in programs that do work. So a milestone, if you will, in the implementation of that. Secondly, when Donald Trump ran for office, he said he wanted to increase job growth. We know that small businesses are a major driver of job growth. So one thing Congress has done in this first year of Donald Trump's administration is attempted to repeal some of the burdensome regulations passed by the Obama administration in their last 6 months, which are said to account for about $67 billion in regulatory cost upon small business. To repeal those if we did not see an adequate benefit for the expense. The one that I sponsored that passed is called the Volks rule, named after a company in Prairieville, Louisiana, the Volks company, V-O-L-K-S. Under the Volks rule, the Department of Labor, I think it was it says the federal government, I think it was the Department of Labor, was requiring companies to keep records for 5 years. The statute said you only have to keep them for 6 months. But they're being kept for 5 years, so the Department of Labor could come review it anytime within 5 years. Well, for a small business, this is an administrative hassle. You speak to the small business owner, she says or he says, listen, I can't focus on growing jobs because I have the Department of Labor coming to audit my records from something 5 years ago. I want to focus on growing my business, creating jobs. And so what we said, first, the court said you can only do it for 6 months. The Department of Labor said, okay, that we're going to pass a rule to make them keep it for 5 years. And the Volks rule says, no, you have to obey the law. You can't pass this regulation that the small business only has to keep the records as the law says for 6 months. So again, this is part of a $67 billion relief package, if you will, from regulatory compliance for small businesses. The goal being to help those small business folks grow their business and to create more jobs. Next issue I want to highlight that was just passed. The GI Bill was just passed in August, and a couple of the things I had in that, which we have veterans, and they're coming out, and one, we owe them an incredible debt of gratitude. And we want to launch them into the next phase of their life, thanking them for all the sacrifice they have made for our country. And you also want to recognize that that is true. If you want to take care of the veteran, you cannot separate the veteran from his family or from her family. So the provision I had specifically in the GI Bill was the Veterans Educational Assistance Act of 2017 with the so-called Yellow Ribbon Improvement Act, and it extends eligibility for additional educational assistance to the children and spouses of service members who died in the line of duty after September the 10th, 2001. We do other things as well, but just in some way attempting to acknowledge our obligation to the men and women who are serving our country in the cause of freedom. And again, that passed in August. What am I working on now? Having phone calls with or emails with my own staff 2 to 3 times a day, with the White House and/or the Department of Health and Hospitals 2 or 3 times a week on our repeal and replace efforts. Clearly, what the Republican Senate attempted to do did not pass in August. So the question is, what do we do next? We still have a system which is not working, which is not sustainable for individuals and not sustainable for taxpayers. The good example I have, and of course I misplaced it, let's see if I can find it. Moon Griffon. I suspect folks in here know Moon Griffon. He has the radio show that you can call in during the midday. And Moon is telling me about what he is paying on the individual exchanges for health insurance right now. So he does not get a subsidy. He's a small businessman trying to make it work, kind of guy who wants to succeed. So he says that in 2016, his premium was $1,650 a month. In 2017, $2,654. And then he's told that if he stays in his health care plan next year, his premium will jump to $3,600 a month with a $5,000 deductible and an extra deductible for medications. And he's very public about this. He says it on his radio show, so I will repeat. He's got a daughter with special needs. He cannot not have insurance. And so he is going to be paying over $40,000, roughly $44,000 a year before his deductible and before his deductible for his medications this coming year. That is not sustainable. Folks speak about Medicaid, and keep in mind the Medicaid expansion has worked really well for some states. The states, though, currently, the federal taxpayer, us, the federal taxpayer is paying 100% of that Medicaid expansion, which now begins to shrink. Still a good deal for the states in one sense. By 2020, the states will be responsible for 10% of that cost. But let's just talk about what happened when the federal taxpayer was paying 100%. States paid Medicaid managed care companies top dollar, and they enrolled as many people as possible. And now they're going to be responsible for only 10%. But that only 10% in Louisiana will be $310 million a year in 2020. In California, it'll be $2.2 billion a year. And when you speak to state legislators, they tell you, oh my gosh, Medicaid is swallowing our budget. Tuition is rising because there's less support for public universities because Medicaid is swallowing the budget. And we're having a hard time with capital improvement because Medicaid consumes more and more of our budget. You can look nationally, and in 1964, this is the amount of money going to public universities from state government, and this is the amount of money going to Medicaid. That's when Medicaid started. In 2009, these crossed, and now state support for public education, public higher education continues to fall, and funding for Medicaid continues to rise. So we have to replace, I think, the Affordable Care Act with something which is sustainable for the taxpayer and which gives the power to patients and gives power to states. If we can do that, and that's what I'm working on, we can achieve President Trump's campaign pledges of continuing coverage, caring for those with pre-existing conditions, eliminating the employer and individual mandates, and lowering premiums. And that is my goal in this Replace effort. What am I doing with both Lindsey Graham and Dean Heller? Well, first I'll say that we're about the only game left in town. Justin Haskins is a commentator for the Washington Examiner, a conservative newspaper in D.C. Ross Douthat similarly is for the New York Times, and both have basically said the only chance Republicans have left for Replace would be the Graham-Cassidy-Heller amendment. And we would take the dollars the federal government is spending through the Affordable Care Act. We'd first repeal the individual and employer mandates, and there is some revenue loss there. We would take those and the medical device tax. We would take the other revenue and we would give it to states based upon how many people in their state were eligible as a flexible block grant, allowing states to come up with their own solutions. You can imagine Alaska, which has 700,000 people stretched over a portion of the United States which is almost as large as one half of the lower 48, has a different set of issues than Washington, D.C., which has the same number of people, but over, 3 or 4 or 5 square miles. There's going to be a different solution. So we allow those states to come up with those different solutions. What can we say? And if the state decided to continue to enroll somebody in Medicaid, they could. But if they decided instead, as Arkansas did, not to put them into Medicaid, but to put them in a Blue Cross insurance policy, they could do that as well. The state would come up with a solution that would work for their state. And again, I continue to speak with my staff several times a day on this, and to the administration several times a week. If we succeed in this, we will succeed probably by the end of September. And so we'll be rolling out our information and our formulas over the next couple weeks. The CBO has to score it, and then we'll consider it when we get back. It's not a guarantee, but one thing I will guarantee, that I'm going to continue to fight to come up with a plan that fulfills President Trump's campaign pledges and returns power to patients, returns power to states, and is both fiscally sustainable for the individual as well as for the state taxpayer. Let me speak briefly about the National Flood Insurance Program. Something near and dear to a lot of folks across the state of Louisiana. I've advanced a bill to reauthorize the National Flood Insurance Program, co-sponsored it with Kirsten Gillibrand, Senator from New York. Unfortunately, both of our states have a lot of experience with terrible flooding. We're pleased about our ideas. If you speak to people in Louisiana, they'll say, oh, that sounds like my idea. And turns out they were probably right, because we did a lot of talking to folks, finding out what their thoughts were, and then with those thoughts trying to come up with a plan that would work. And our goal is to create an affordable, sustainable program which is accountable to the federal taxpayer. And so that's our goal with our reauthorization of the National Flood Insurance Program. What do? We reauthorize the National Flood Mapping Program for 10 years. We increase the accountability of NFIP contractors. We use different mechanisms to lower the cost of premiums, but to maintain the coverage that is available to someone. We have some innovative pilot programs, such as a risk-sharing program with the Write Your Own companies. We have significant investment in flood mitigation, $400 million a year over the course of the program. To put that in perspective, Congress has only spent about $200 million over the last 5 years on mitigation. This would be $400 million a year. A stitch in time, if you will, saves 9. If you're required to elevate your home, currently you only have $30,000 to elevate your home. That's not adequate. We increased that amount to $75,000. In fact, there was an article in The Advocate of a conservative think tank, libertarian think tank, saying what we should do as a nation to reform our national flood insurance program that ran yesterday. And I meant to bring it with me, but almost everything that they are suggesting, we have in our policy. We encourage the use of high-resolution mapping technology. For example, right now, floodplains are made as an average, but if one person really attempts to mitigate her risk of flooding, she doesn't necessarily get credit for that. We would use LIDAR to say, your floodplain level is at 6 feet, but this home is at 10 feet, so therefore they will get a lower premium, and this home is at 1 foot, and so they will get a higher premium. It just makes sense. So we're trying to do that to incentivize folks and to reward those folks who do, to decrease their personal risk of flooding. One thing that's near and dear to a lot of folks, or I should say bitterly dear to a lot of folks, as it currently stands, we're going to reform the proof of loss requirements. As it currently stands, homeowners have to submit a proof of loss within 60 days that requires them essentially to present all their evidence of damage within 60 days. It's not fair because homeowners generally rely entirely on the Write Your Own agencies to figure out the scope of damage and draft the proof of loss statement. We changed the 60-day proof of loss to a loss notice provision, giving the Write Your Own timely notice and plenty of time for a fair estimate. For folks right now who flooded in the great flood of last year, they'll know exactly of which I speak. And lastly, just to mention, I get as much conversation about this as almost anything else, we attempt to do something positive about access to red snapper, trying to increase the recreational access, if you will, for Louisiana families. And I introduced this with Garrett Graves and Senator Kennedy, Clay Higgins, Cedric Richmond are also on the bill. And we're just trying to give the state authority for red snapper management within 9 miles of the coastline, giving the state authority to set fishing seasons in a new area from 9 miles to depths of 150 feet, but no less than 25 feet. We retain the federal management of federal charter and commercial fishing industry, and we include resources to increase the catch and release survival rates. We do other things as well to protect the species, but we think it's a good bill. We've worked with stakeholders across the spectrum to find something that addresses the needs and concerns of stakeholders across the spectrum, but ultimately to increase access to recreational fishing for the folks of Louisiana and elsewhere. I'm proud of what we've been able to accomplish. I'm very honored the people of Louisiana have given me the privilege of representing them in Louisiana. representing the state of Louisiana in Washington, D.C. And I am doing my absolute best to honor the trust that they have given. That said, open up to any questions. And Julia, do I turn it over to you, or you tell me how I do this?
I don't remind people of one thing.
Yes.
I know lots of people want to talk to Senator Cassidy. We're trying to take questions from media organizations and press club members. So before you ask your question, if you could identify who you are, that would be very helpful. Thanks.
Yes, sir.
Ron Stage from the Pineywood Journal newspaper, North Louisiana statewide paper. My question is, Canada is dumping lumber at a very low price on the U.S. market, and it's devastating the timber industry in Louisiana. It's a $2.9 billion industry. What are you guys doing about that? And secondly, what are you guys going to do about the national debt in September?
Yes. So from the Piney Woods Journal, and representing the Piney Woods Journal, of course you might guess I'm repeating this for the people who are watching online and on television. What about Canadian dumping of lower cost lumber into the United States, undermining the kind of business model of our folks? You could probably add Brazil as well. President Trump clearly is concerned about Mexico and Canada using provisions of NAFTA in order to protect their markets, but to allow them less restricted access to ours. And I think he has recently said that he doesn't want to completely get away with NAFTA, but he certainly wants to revisit it and find out on issues such as this, issues such as dairy, also concerning Canada. Is it still a fair deal for the United States producer of lumber, producer of milk, the United States taxpayer? And so I think this is going to be all part of President Trump's trade agenda to re-look at these sorts of arrangements and address those issues which you just mentioned. Lastly, regarding the national debt, raising the debt ceiling will be raised. Whether it is with conditions or not remains to be seen. Yes, sir.
Robert Burns with Sound Off, Louisiana. There's some reports that you are actively lobbying the Trump administration to appoint Stephen Street as the next U.S. attorney for the Middle District of Louisiana. Are they accurate?
No. Steve Street's a good guy. But let me explain the way that our process has worked. Let's pick a judgeship. By the way, the question was, am I actively lobbying the Trump administration to appoint certain people for certain positions? The way it works is the president appoints, and I nominate. For some positions, we'll nominate one person, but for most positions, we nominate more than one. For example, judgeships, I'm not a judge, I'm a gastroenterologist. I don't know if a particular attorney has a good courtroom demeanor or not. So I've appointed just people I trust, my chief of staff among them, who's an attorney, a couple of business folks, to review those people who are applying. They bring to me a list of 3 or 4 people, sometimes longer. I interview and then send that up to the administration. And then they are the ones that make the pick. So it's kind of a hands-off process, a little bit of involvement. But yes, ma'am.
So I want to go back to what you were saying about legislators and hearing about Medicaid swallowing up the budget. I think we do hear legislators complaining about that. I guess right now what's swallowing up the budget is the traditional Medicaid program in Louisiana. So I'm curious if your comment means you want to make changes to, Medicaid as it's operated for decades, or just for expansion, and can you be more specific about what those changes might be?
Yeah. So Julia asked that. Let me rephrase your question, but I think you'll accept the way I rephrase it. She asked about different parts of Medicaid, and if you will, there are different types of Medicaid. There's the traditional Medicaid, which folks remember pays for nursing home care, pays for blind and disabled, pediatric program. There's actually the CHIP program, which is specifically for the pediatric population, parts of it. And then there is the Medicaid expansion. Now, she mentioned that legislators are complaining not about the Medicaid expansion because to date the federal taxpayer has been paying 100%. They're concerned about the traditional Medicaid. So And in that case, instead of the state paying 10%, as it will for the Medicaid expansion in 2020, it has to pay roughly 35%. I forget the exact number now. Roughly 35%. So, yeah. So as it turns out, the traditional Medicaid program is a huge problem. And this is despite the fact that Louisiana, like almost every other state, uses a variety of financing gimmicks in order to minimize their exposure. Now these gimmicks are legal, but it does decrease the amount the state taxpayer has to put up, but it pulls down a lot more from the federal taxpayer. Since you and I pay both federal and state taxes, this is of incredible importance to us. And the traditional Medicaid program continues to have its problems of financing. In the legislation that we propose, we probably will have the per beneficiary payment that has been discussed in Washington, D.C. Folks are a little nervous about the per beneficiary payment because they're used to the state being able to send whatever bill they want to the federal government and the federal taxpayer paying it no matter what, even if the care is not particularly good or effective. That's not good for the patient, and it's not good for the federal taxpayer. So the proposal that, so the way states have addressed this so far is they've gone to Medicaid managed care. They will go to Bayou Health and they will say, we're going to give you this amount of money for this type of patient because we think this is about how much that caring for that patient is going to cost. And you're an insurance company, you know how to manage risk. You're going to put in programs to make the patient healthier, to spend less money, and at the end of the year you'll make a profit. That's okay, but we at least have some certainty as to how we're going to spend. What a per beneficiary payment does on a federal level, it says to the state, listen, you're putting everybody into managed care, and you're paying about that much per person into managed care. The federal taxpayer is going to give you about that much money plus a little extra. The federal taxpayer will do for the state what the state is doing for the patient in the Medicaid managed care company, which is to give you a certain amount per patient. This has been employed by almost all states in terms of Medicaid managed care, and probably we'll end up having a provision like this in our final bill.
So are you looking at changing in your bill both Medicaid and Medicaid expansion, how they operate now?
So the question is, are we changing both Medicaid expansion and traditional Medicaid, how they operate now? Not for all of it. For example, blind and disabled children are carved out. Very hard to predict the cost of blind and disabled children. So they are carved out of any sort of per beneficiary payment. There's a couple other populations which are carved out. Anyone else? Yes, sir.
Senator, I wanted to take the opportunity to thank you for being so responsive to the citizens of Louisiana, particularly on this health care bill. I know you have teamed up with a number of other senators trying to make it work for it. And I just trust that you will continue to be patient and make sure that we get a good health care bill.
Thank you. That is my goal. The comment was observing and thanking that I've attempted to work with other senators in the repeal replace effort. What I mentioned about Moon Griffon paying over $40,000 a year for his premium, that is not unique to Louisiana. There are 11 states in which the individual market is said to be failing. That does not include Louisiana, even though someone like Moon is paying over $40,000 a year. That is not considered failure. To show you kind of the problems that are present in the individual market. And I have reached out to both Republican and Democratic senators trying to find common ground. And the proposals we put forward have been very conservative, but things that liberals could like. We give the power to the state to come up with a system that works for that state. We do repeal the individual mandate and the employer mandate, but if the state of California wants to put those taxes back on their people and put those taxes back on their businesses, they can do it. That's not a federal restriction. That's just a state decision about the state having the will to do it or the need to do it. On the other hand, if you're a state like Louisiana that says we don't want to, but we have our own thoughts how to come up with our own system, it's a positive thing. I will add the bill that we put forward. Ted Cruz, Senator Susan Collins and I had a bill we put forward. Ted Cruz took a provision of it, and we'll include the Cruz amendment in our final bill, which is allowing an individual to use a health savings account to purchase insurance premiums. I love this. Whoever controls the money has the power. I worked in the charity hospital system. The patient did not control the money in the charity hospital system, so the lines were long and the buildings were decrepit and the technology was old. And we had dedicated doctors and nurses, but lines were long, the buildings decrepit, the equipment was old. So under this Cruz amendment, married with what we're trying to do with the Graham Cassidy Heller, the state could take the money it receives, pre-fund a health savings account, allowing the individual to purchase the insurance that she chooses. She can pick the policy that works best for her and/or her family. She has the power. I love that, and I'm very pleased that Senator Cruz has put that up. Lanny?
In the short term, sir, there's some question. Blue Cross, the last number I remember is from memory was 18 million that Blue Cross had already spent on the subsidies for various policies. The White House has not said whether it's actually going to pay those bills. Is part of your measure to make that a matter of statute that those bills be paid?
So
What
we'll.
do you do if the White House says no?
Although I am optimistic. There's several. First, I'm sorry. I'm supposed to repeat the question, and it was kind of a long question.
Sorry about that.
The point was that there's something called cost-sharing reduction payments that go to insurance companies that reduce the premium for some of those in the individual exchanges. The White House has been iffy as to whether or not they will continue them. Blue Cross Louisiana is concerned about it. What will we do about that? Is that a fair summary of your question? So, let me kind of work through it. Senator Lamar Alexander and Senator Patty Murray, who are chair and ranking member, ranking Democrat of the HELP Committee, Health, Education, Labor, and Pension, a committee upon which I sit, will begin holding hearings in September to authorize a temporary extension of the cost-sharing reduction payments through the end of 2019. That's the plan right now. Very narrowly focused, stabilizing the market. I'm all about that because the more unstable the market becomes, the more people's premiums go up. And a Moon Griffon is spending $40,000 now, you don't want them to rise by another 20 to 40%. That cannot be done through our legislation, because even though I am hopeful and even optimistic that some Democratic senators will vote for our legislation at the end, the reality is that under the rules of the Senate, that these cost-sharing reduction payments cannot be inserted into the bill that we are drafting. So if you will, what we're doing, Lonnie, complements what Alexander wishes to do. It does not compete with it. Yes, sir. Hey, Jeff.
Senator, what needs to happen for your legislation to pass? What are, for Republicans that are still on the fence about it, what's it going to take for them to get along, to agree to this plan? I mean, are they waiting to see how many people will be insured, and is there any chance that you can actually get Democrats to also support it?
So Jeff's question is, what will it take for, I'm pretty sure you meant the repeal,
Yes.
the Obamacare repeal legislation to pass.
Right.
Have good legislation. So that's the key thing. The legislation that we have now would take the dollars the federal government is spending on the Affordable Care Act, and after repealing the individual and employer mandate and the medical device tax, take the remaining dollars and spread them evenly across the United States, no matter where that American who needs assistance lives. Under the current system, Massachusetts it's an expansion state, and I'll be a little rough on these statistics, but conceptually I'm right. Pennsylvania and Massachusetts both expanded Medicaid. Pennsylvania has roughly double the population of Massachusetts, but Massachusetts receives about 2 times more money than Pennsylvania does under the provisions of the Affordable Care Act. Massachusetts has an incredible expensive cost of care, and they have figured out how to maximize federal dollars. That is not fair. If you're an American who needs assistance in Pennsylvania, Massachusetts, Louisiana, or Alaska, the federal taxpayer should give about the same amount wherever you live. You need to adjust it for some things. When you're younger, you have less health care needs. When you're older, you have more. When you are, you can think of different reasons why some folks need disease burden. One of the reforms we hope to have in this legislation is that disease burden is brought into the calculus as to how much folks get. But still, what you receive should not depend on whether or not your state government has figured out how to maximize reimbursement. It should be somehow rooted in fairness. Now, by the way, why am I somewhat optimistic that maybe a Democrat would vote for it? Well, some states represented by Democratic senators will do well. They will do very well under our system. And that's on purpose. Because if you decide to be fair to someone, it doesn't matter whether they live in a red state or a blue state or a purple state, you've decided to be fair, and it just turns out that they may do better off, and they happen to live in a state represented by a Democratic senator. And we're just trying to bring that sense of fairness to this piece of legislation. If we do that, I think we will have the sort of policy that will endure. It won't be that if we have a Democratic president sometime in the future, that Democratic president says, oh, we have to revisit it. They'll say, no. What was done is fair to all. It's working. We're going to stay with it. That's my goal. Yes, sir.
Sir, do you have an analysis as to...
They ask you to identify yourself. I'm sorry.
I'm sorry, I can ask just a number messed up. Have you, or your folks done an analysis as to whether if Congress ever had the nerve to do it, repeal McCarran-Ferguson, or either give authority to negotiate drug prices, how that would affect things, or your plan, or the current plan, or anybody's plan?
So you got two questions in there. One was, what about repealing McCarran-Ferguson, which is one of the things that has many provisions to it, but it allows, probably in the context of healthcare, which I think you're asking about, it's one of the things that limits the ability to sell across state lines. And secondly, what about pharmaceutical costs, allowing the federal government to negotiate for pharmaceutical costs? Fair statement?
Yeah.
Great questions. Great questions. The president has been all about allowing insurance to be sold across state lines, and it works in some markets. Obvious example, Texarkana, right? You live in Texarkana, you can be, it's like a Geico commercial. You know, you can have a foot in one, you can be a lizard and have a foot in one state and another foot in another. And so it just makes sense. But I know as a physician that most times when insurance companies come up with their rates, they go to a community and they say, okay, what do the doctors charge in your parish, your county, and what is the disease burden in your parish and county? So if you live in Opelousas, you're not going to be able to get a deal from an insurance company based in Chicago because their rates are based upon physicians and disease burden in Chicago, not Opelousas. So I do think there will be some provisions either in our bill or other bills, allowing states to sell across state lines, but you'd have to give the insurance company the ability to refuse, because if they have come up with an analysis that works in Chicago but not in Opelousas, they shouldn't be required to sell in Opelousas nor vice versa. That's first. Secondly, as regards drug pricing, that's interesting. I know a woman, she is oh my gosh, she is a Republican. She's a Republican. And she wears red every day of the year. And she is so upset about how much she is spending on her medication. It's off patent. It cost about 10 times what it cost 8 years ago. And if it cost, according to drugstore.com, $140,000 for her pill in the United States, it cost $8,000 in Canada. That's enough to get people's blood boiling. Another guy in Lafayette, another Republican, I'm sure his underwear is red. His daughter is a diabetic, and he has always emailed me as to what his daughter is paying for her insulin. So we have to find out, we have to find ways to address high drug cost. I have been working with Secretary Gee of Louisiana's Department of Health to try and come up with a way to bring hepatitis C treatment to people in Louisiana on the Medicaid program. Right now, the treatment for hepatitis C is incredibly expensive. So much so that if the state of Louisiana decided to treat everybody who had hepatitis C, it would go bankrupt in 3 years. I'm a hepatologist, which for folks who don't know what that means, that's a liver doctor. I always have to explain it because otherwise they think you're doing snakes or venereal disease. But I'm a liver doctor. And so as you might guess, I have an interest in this. And we're trying to come up with a market-based solution that would allow that treatment to be offered on a broader scale. Why do I say market-based? It's real easy to say, oh, we're just going to march in and we're just going to take over the intellectual property and we're going to take that from the drug company and we're going to give it away for free. That's great. And then the drug company doesn't work on a cure for AIDS or a cure for Alzheimer's. So we have to keep incentives for drug companies to continue to work on life-saving drugs. But we have to figure out market-based solutions that bring competition into the market, that allow access to drugs, which in some cases are priced so high, people don't have access to them even when they're life-saving. I don't have an answer on that just yet. I can tell you I've been working on it for 2 or 3 years, and we'll continue to, we're actually drafting legislation, but we're kind of in the midst of it. I didn't bring it up today until I asked the question. But it was on a phone call this morning on that very topic. I'll continue to work at it, sir, and try and find a solution. I am so aware of how important that is. I'm sorry, you haven't.
Rebecca Allen with The Advocate. You talked about Medicaid expansion becoming unsustainable for states once they have to cover 10%. Here in Louisiana, the health officials say that they actually think it will be manageable because of savings that they're getting from uncompensated care costs and the managed care taxes. I mean, do you think that that is too optimistic or unrealistic?
So the question is, the people in Louisiana, the officials in Louisiana feel like they will be able to pay Louisiana's share of the Medicaid expansion because of premium taxes and other things that they have put in place. First, let me say in general, Medicaid is like a black hole. It just sucks in every other source of expenditure. And if your society has a certain amount of tax burden, the more of your tax burden you devote to any one thing, there is less available for others. So it may be they have premium taxes and provider taxes that can currently pay or are projected to pay for most of Louisiana's share of the Medicaid expansion population. But I will say there's no free lunch. And at some point, you have less ability to address other needs. But secondly, let's look at these mechanisms that are being used, because this concerns us as federal taxpayers. I'm speaking not as a state taxpayer, but as a federal taxpayer. The way that states have paid their share of what they need to pay to pull down federal dollars are by what are called financial gimmicks. So they levy a 6% increase on a tax, if you will, a 6% tax on what a hospital has to pay per bed. And so the state gets all this money in, and they put that money back up to the federal government. But then they increase their payments to the hospital by enough that the hospital is held harmless. So the hospital on net does not pay a tax. Now you can say, well, that's a great deal for the state. Well, they do pay a tax, but they're held harmless, so it really doesn't deprive them of working income. Now you can argue and say, well, isn't that a great deal for the state? Not a great deal for the federal taxpayer. We as federal taxpayers are seeing more and more of our federal tax dollars going into Medicaid, Social Security, interest on the debt, and it's important to pay the interest on our debt. Medicaid, important program, But the amount of money our country has left over to spend on the Army Corps of Engineers is declining. The amount of money we have left on defense is decreasing. The amount of money we have left on spending on anything else is being shrunk because so much is being spent every place else. So my goal is, how do we find a way to sustain and strengthen these important programs? They're providing support for Americans who need it, but in a sustainable way, which doesn't just see this as an economic development project, let's pull as much money as we can from the federal taxpayer, again, that's you and me, in order to float the boat in the state. That may work for the state, but it doesn't work for the country. And it may work for state government's budget, but it doesn't work for our personal budget, because ultimately we pay more in federal taxes. I could go on, but I think that's kind of a second order response. I am told I am out of time. But I thank you all so much for your attention, for the questions, and for the opportunity to communicate with you. Thank you.